Okay, well, thank you very much. This is my first time presenting in the dark, and hopefully I'll shine some light. This is actually a pretty fun presentation for me personally because I actually had a lot of fun developing the slides. So basically, ovarian cancer, you guys are the expert, but to me, it's like a whack-a-mole disease. This is a very interesting disease that you sort of whack up with a chemo doublet. And for some patients, actually, it's a cure, but majority of patients, they eventually, after the chemotherapy, you watch and wait for approximately 13 months or so, and then eventually cancer will come back, and then you have to whack again. And then you do the watch and wait, and this time you actually only watch and wait on the average of 4.7 months, and then the tumor come back, and eventually what you see is the tumor come back faster and faster, and you went into the scalloping phase. So this is sort of history, and actually these tumor now we know is actually quite heterogeneous to begin with, and as they sort of progress and treated with many different chemotherapy, they become more and more heterogeneous. So then an ovarian patient actually change what they want over this course of period of time. We actually did some patient like me sort of interview, and also Laura from Duke also did some analysis where she basically gave these people 100 coin, 100 tokens, say tell me how you want to distribute this. And it's very interesting in that before the chemotherapy, the first chemotherapy, before just at the time of diagnosis, all they want is cure, cure, cure. But after the sort of first chemotherapy and they actually got the first recurrence, their attitude changed. And actually, it's interesting, you can see on this graph is that they actually now, if you give them 100 coins, they don't put everything in overall survival. They actually put more of the coins to the quality of life. And clearly, they realize, quality of life is important. They know the cancer is going to come back. Cure is not everything. So they actually, if you look at this, they value the OS and PFS about the same. OS a little bit more, but not too far behind. But quality of life actually is the most important things. And this is what we struggle as sort of drug developer is sort of what is live longer, and if it's not live longer, you want to live better. And how did you measure that? And the other thing about ovarian to me is very interesting is that even our market forecast person actually got it wrong is that a lot of ovarian cancer do survive a very long time. I think Patricia just told me she's more than 20-year survivor. So actually ovarian patient can survive a long time. It's not uncommon for people to have 10 chemo, 12 chemo, and etc. And this is actually also cause an issue in internal drug development because our goal, our way of measuring is always OS. But you can actually do computer simulations and see how OS will dilute as the distance between progression free PFS and OS getting longer. For example, in this table, you set up the computer to hazard ratio 0.67 for the PFS, and you say if they're just 2 months different between OS and PFS, how much does this hazard ratio for OS going to get diluted? And you can see it actually doesn't get diluted that much. It's around 0.687. But if you do a 12 months difference between PFS and OS, it actually now get diluted to 0.749. The reason is that if you go out, have a car accident, have a heart attack, nothing related to your cancer, it actually all diluted out on both arms. And that's one of the reasons. And if you go to 24 months, the distance between PFS and OS, now it get diluted to 0.763 hazard ratio. And if you take Lynparza or Olaparib's case, where we actually have a very impressive hazard ratio in internal PFS, hazard ratio 0.18, and you actually plug in the computer model, even without consideration of crossover, and what you get, because the SPP, the distance between PFS and OS, is 24 to 27 months, you actually get a diluted to 0.83 internal OS hazard ratio predicted by computer model. And our actual actually came below that, even with 23 percent crossover, our actual hazard ratio is 0.73. So you can see that, in the long run, as we make progress in ovarian cancer drug development, eventually you're going to be a very hard time showing OS. And this is actually a paper. So the question is, what can we do? This is going to be very hard. So this is actually a paper that I wrote with Ursula and Amit Oza and Jonathan Liederman, in that you can see in a sort of the panel A, that's the ideal case, right? You have a natural history, eventually patient will die, and you're trying to give a therapy intervention. This shift the PFS, and people will have also concomitant equal amount of OS prolongation. But if you have a very effective therapy in panel B, and that actually catch the intervention curve, then the crossover can also dilute out your OS benefit, or the natural dilution factor I was talking about. That could be another potential explanation. But there's also another reason you may not see PFS and OS difference, is in that your drug may have long-term toxicity. An example of this could be that a drug like adriamycin that may have cardiomyopathy, in the long run, patient may not die of cancer, but they die of sort of CHF. And then you actually have you need to balance your OS benefit with OS detriment. And that's why, so it's very important. And this is where in panel C, there's sort of the middle ground. We don't know exactly what happened, what factor is important. So another way to sort of trying to answer this question, we actually trying to do this, is look at intermediate endpoints. And this is a very important endpoint in that, for the statistician in the room, is that this is actually start with a randomized population. And basically everything is Kaplan-Meier curve, and you censor along the way. So all the endpoint, you preserve the original randomization. So this way give you a very balanced way of answering questions. And we can see that traditionally we have a PFS endpoint, which is a RECIST objective endpoint. Is a picture on the radiograph. But physician actually, for those who practice, they know they don't practice on RECIST, right? You don't treat right away when they have RECIST progression. And the next thing you can measure sort of subjectively is time to discontinue treatment. And that's a behavior that you're measuring. And then after that, you have time to first subsequent therapy. And that's what really truly impacts. So if you give a drug, you can say, I stopped the PFS. But then the question is, what does it mean? Does it change the behavior of physician and patient? Do they actually do something different? And that's where you measure by something pretty subjective and pair that with the objective endpoint, time to first subsequent therapy. But then often the question is that, well, if you give this treatment here, does it have an impact on the next line of treatment? And this is where the next endpoint, which is advocated by EMA, is PFS2, another objective endpoint where it's RECIST measurement. And this is actually the better way to measure them, rather than just taking those people who progress and give them chemo, see if they respond to chemo, because then that's no longer a randomized population. The PFS2 is still a randomized population. And so you can see, well, these patients no longer on the drug, and does my treatment effect, if I make the decision on day one of randomization, does the benefit continue on to the next line of therapy? And then, of course, we want to pair that with a sort of physical, more subjective behavior. Does the next chemo, the second time to second subsequent therapy, change? And that's actually a TSST that we pair along. And then, of course, you have the OS, the ultimate objective endpoint, which is not, one thing is that OS is not just an efficacy endpoint, just as good as safety endpoint. So that's sort of something. So we actually did that for Lynparza, and think you may have heard this at the ODAC. Basically, we show that we do have a very strong PFS benefit, 6.9 months difference in the PFS. Then that actually translated to time to first subsequent therapy of 9.4 months different against placebo. And we were actually kind of curious about that. Say, well, gee, how come it got longer? And turned out we have found some of the physicians, which is protocol allow, is that continue treating the patient with Lynparza, even though they met the RECIST criteria, because they actually think that the drug actually holding the tumor from progressing that fast. Then you look at the time. We don't have PFS2, unfortunately. We didn't design the trial, but we do have the time to second subsequent therapy. Then again, you can see in this randomized Kaplan-Meier curve, you see a 8.6 months difference. There look like there starts getting some dilution treatment effect. The treatment effect is not as big as sort of what we see in the PFS, which is expected. Then, of course, in the OS, now it's diluted down to 3 months, and it's not statistically significant. So this is how we have been using this endpoint. And then the next thing just want to talk about is I know there's a lot of PRO experts in the room, so I feel kind of humble trying to talk about this. This is actually a passion of mine, internal patient-reported outcome, and I think there's quite a bit of confusion. What is a PRO? PRO is basically anything you ask the patient to fill out as PRO, patient-reported outcome. It can measure, for example, symptoms or side effects, but symptom and side effects not quality of life. I think people get confused about PRO equal quality of life. PRO does not equal quality of life. When you measure symptoms, quoting sort of EMA's point of view, symptom is just say, it's a subjective verification of PFS, right? And that's progressive symptoms. And side effect is side effect, and you can measure different drugs have different side effects, and that does not represent quality of life. And what quality of life, you can just ask the patient, what's quality of life to you? And that's really, can I work? Can I enjoy life? Can I function? Can I go to see my family and friends? We heard that this morning, actually. So that's sort of, and also you can have other PRO, for example, measuring health status. That's different than quality of life. Adherence to treatment, that's a PRO too. You ask patient, did you stick to the treatment? Or satisfaction with treatment, that's a PRO. But that's not quality of life. So I just want to make sure people do understand. So of course, to measure quality of life has always been a challenge. We try to do that in schizophrenia, depression, pain area, and usually typically with paper and pencil. I can tell you, actually, the best quality of life instrument I've seen, or measure some type of sort of how do people feel, is not your 40-question questionnaire, but it's mostly global impression and change. It's actually more powerful than anything else. The patient actually can tell you, am I better off than when I start out with? And that turned out to be most sensitive statistic-wise across different disease areas. 2 minutes. OK, got it. And of course, with the new Apple Watch and smart devices, I think this is something will be very interesting. And finally, this is like to bring some of the mathematical oncology into this. As tumor we know is heterogeneous, and the other thing we also know is easier to kill a 2,000 or 3,000 tumor cell than kill a million cells, because a million cell has more chance of developing resistance. So this is where in the oncology, I think ovarian, instead of watch and wait, what people do is you whack it with chemodopplers. The tumor actually disappears. This could be hibernating tumor cell or stem cells. But then eventually they sort of grow up, and you whack again. So instead of waiting for them to grow big, what you want is actually has a maintenance therapy during this watching period and watching over the patient. Even a single cell wake up, you can kill it. And this is actually what we see in the Lynparza case, where you actually see that you can treat these patients early. You actually have better objective response rate, and they're less heterogeneous early on. And we have like 65% objective response when you go just 2 prior lines of therapy. And so actually, I covered that. Instead of washing away, we do Olaparib maintenance therapy. And the other thing, finally, the last slide is actually I was trying to look other therapeutic area. And Hep C actually, to me, is a super interesting area where they actually start with immunotherapy, alpha interferon. And that time, when they just have one single therapy, there's no cure. But when they add on to the second targeted therapy, a nucleoside analog, such as ribavirin, all of a sudden they start seeing cure, 28 to 62%. And when they go triple adding a third agent with a protease inhibitor, now they're seeing sustained viral-free or cure of 75%. And then when they improve it, you get to 90%. So this is actually, I think ovarian cancer is actually very exciting now. We're in the cusp of sort of making these moves. I think, for example, Lynparza's approval may be the first step. You have the first guardian after the tumor disappear. You have the Lynparza that you can take every day. Every single cell that wake up who lost their functional BRCA genes in their tumor cells, Lynparza is there to kill it without you knowing it. But that's not enough. Eventually, your luck going to run out. You can develop resistance to Olaparib. And this is where I think exciting thing is that immunotherapy or anti-VEGF, some of the Joyce Liu's data, Joyce Liu showed that if you combine Olaparib with Cediranib, there's actually treatment efficacy appear to be even better than chemotherapy. And if we combine, so that's goes double, right? And if you can combine that with another guardians, such as immunotherapy, hopefully one day we will see this picture where you have the tumor, but you don't even take the chemo, you take the triple therapy, and the tumor may try to come back every time you wake up trying to come back, but there's 3 guardians around there to kill these tumor cells. And so eventually you get to the cure, and we will be talking cure hopefully in the next meeting we meet. So I'll stop there. Well, thank you.